passare la parola con grande piacere alla professoressa McWilliams che, per la sua relazione, il cui titolo è Differenze di personalità e loro implicazioni per la psicoterapia. Prego.
Thank you very much. Are you all hearing me okay? Okay. Thank you for inviting me. I wish I could be in Milano in person. I was hoping to get there, but I'll have to do it another time. I want to thank Antonino Aprea for inviting me, also Marco Longo and Silvana Cohen. And I want to thank my translator, Paola, who is doing a wonderful job. I'm going to show some slides, but I want to tell you first, they're in English. Don't try to read them carefully. They will go by too fast. It was my way of adapting to the fact that I have a very short time to talk. So on the slides are all kinds of citations and elaborations that I won't be able to say in my talk. Let me share my screen now. Okay. Many of us choose a vocation in psychotherapy because we were fascinated with individual differences. Research on therapy outcome supports this focus. Personality and relationship variables are consistently found to have more influence on outcome than type of treatment. One of the strongest aspects of the psychoanalytic tradition is its more than 100 years of thinking about personality structure and internal subjective experience from different perspectives. This lecture will cover 10 ways of thinking about personality differences, with emphasis on the clinical implications of each angle of vision on individuality. These different perspectives are relevant to the individual psychologies of both therapists and patients and to the fit between them. The PowerPoint slides contain citations relevant to each of the 10 perspectives on individuality. All these ways of viewing individual personality differences are supported by a significant clinical and empirical literature. And I'm happy for people to have these slides after my talk. I'm happy for them to be translated into Italian. I will send them to you and you can do as you wish with them. First, temperament. Scientists finally figured out in the late 1970s and later what every parent with more than one child has known for millennia, namely that we are born with different inborn temperaments. The causes of such differences are not simply genetic, but may derive from specific intrauterine environments affected by the mother's stress hormones, nutrition, drug and alcohol use, medication, and other factors. Temperament is quite stable over time. Although psychotherapy and psychoanalysis have historically emphasized therapeutic efforts to help people to change, therapists have learned to attend to what cannot be changed and to help the patient accept such realities. For example, individuals with very sensitive temperaments, with a constitutional tendency toward introversion, may want to become more sociable, and it is possible to help them with this goal. But they need therapists to understand that they will never be temperamentally gregarious, that social interaction is painful for them, and that they need to value the positive features of their shy temperament and not hate themselves for being unable to find social interaction easy. Second, attachment style. The theoretical innovations of the psychoanalyst John Bowlby and the research designs invented by his students, especially Mary Ainsworth and Mary Main, have led to a mountain of empirical research on individual differences in attachment that is increasingly influencing clinical theories. The original findings of this research suggested that there are 3 normal attachment patterns: secure, ambivalent insecure, and avoidant insecure. But these studies were originally done with cooperative middle-class families. When research was done with children from more disturbed and traumatizing backgrounds, a 4th attachment style emerged from the observational data: disorganized, disoriented attachment, or type D attachment. In the strange situation paradigm that has been used to study children's attachment patterns, children with a secure style are able, despite some anxiety, to separate from their mothers and play in the strange situation, and they show pleasure during the reunion with their mothers after their short separation from her. Children with an anxious attachment style cling to the mother, seem preoccupied in the strange situation, and are angry with the mother upon reunion. Children with an avoidant style seem indifferent to separating from the mother and appear to engage readily in the strange situation activities, but measurements of their stress hormones show they are managing very high anxiety. On reunion, they seem indifferent to connection with the mother. This attachment style has been related to psychoanalytic writings about schizoid psychology. In children with a disoriented, disorganized attachment style, the mother seems to be experienced as an object of both safety and fear, a safe harbor and a stormy sea. A child with this pattern treats the mother in contradictory ways. For example, clinging to her and biting her at the same time. Clinicians treating patients with significant trauma histories can attest to a comparable experience in their psychotherapy. Such patients may look upon the therapist as a life-saving healer and at the same time treat her as a dangerous persecutor. This type D attachment has been associated with more severe versions of borderline psychology, borderline personality disorder, and complex dissociative and post-traumatic disorder.
Paola, scusami, le slide della professoressa McWilliams non scorrono, è una scelta che ha fatto. Grazie.
Oh, really? They're not moving. Oh, they're moving on my screen. Okay. Let's see. Let me ask the technician if there's something I can press. Yes, would you?
Sì, Paola, se traduci tu per favore. Credo che abbia attivato la presentazione e quando si attiva la presentazione Zoom lascia la schermata fissa che stiamo vedendo adesso. Dovrebbe interrompere la presentazione delle slide e fare come il professor Lingiardi, selezionando le singole diapositive.
Ah, thank you for telling me. They're moving now?
Sì, ora funziona.
Okay.
Grazie mille.
You're welcome. Thank you. Okay, I've just covered temperament, how infants differ, clinical implications. I'm in attachment style now. Measured attachment style is very consistent over the lifespan. A person who tests as avoidantly attached in the strange situation at age 4 will likely test as avoidantly attached when given the adult attachment inventory at age 34. Philip Shaver's research has shown that there are 2 circumstances that can move an insecure attachment style to a more secure attachment. First, a devoted love relationship or marriage of at least 5 years. And second, intensive psychotherapy or psychoanalysis for at least 2 years. The therapeutic implications of understanding individual attachment styles include helping patients understand their own attachment patterns and their consequent behaviors in relationships. In instances in which their behavior is making positive or sustained attachments difficult, therapists typically help them to take risks that may gradually reduce their areas of attachment insecurity. As Shaver found, the steady presence of the therapist reduces the degree of attachment insecurity over time. Here are a couple of important recent books on attachment. Next angle of vision, observed clinical patterns. The most common way for psychotherapists to talk about personality differences derives from our having conceptualized them through the lens of what kind of psychopathology individuals tend to have when they run into difficulty. In Freud's era, those who treated patients with hysterical or obsessional patterns, respectively, eventually realized that many of these patients had similarities of personality, not just of disorder, and they began writing about hysterical and obsessional character. Early writings by Reich and Fenichel, along with later writings by analysts in the ego psychology tradition, differentiated between the internal dynamics of individuals whose personalities were described respectively as hysterical, phobic, obsessional, depressive, cyclic, impulsive, paranoid, schizoid, narcissistic, and psychopathic. Later analysts wrote about masochistic, sadistic, dependent, passive-aggressive, and dissociative psychologies, and some theorized about other, less common personality constellations that one may encounter in therapeutic work. The clinical implications of working with people as they are seen through this lens includes appreciating their underlying dynamics, interpreting them when possible, and gearing the tone of treatment in ways that take account of the patient's psychology. Clinicians are frequently aware of how ostensibly similar behaviors in 2 different individuals may be expressing different internal issues. For example, perfectionism in narcissistic individuals may be an effort to avoid shame, whereas in obsessive ones, it is more likely an effort to avoid guilt. It is critical that therapists understand their own personality tendencies, as it is easy to misunderstand patients based on projection. For example, a depressively organized analyst may assume when a narcissistically impelled young person reports a sense of internal badness, that he or she means a kind of moral badness, while the patient may be trying to describe a sense of ugliness, insufficiency, and expectation of humiliation. I recommend to this audience the personality section of the second edition of the Psychodynamic Diagnostic Manual, which we tried to make much more comprehensive and clinically relevant than the DSM personality disorder categories, though I want to note that the appendix to DSM-5 with its alternative classification of personality disorders is an improvement over the standard personality disorder diagnoses in that it is dimensional rather than categorical. But even that effort has continued to try to define personality structure in terms of traits rather than the internal themes that have captured the attention of clinicians. I will say more about this shortly. I recommend as well the recent book by Robert Feinstein on personality disorders, especially the chapter by Jonathan Shedler. This clinical paradigm has been immensely valuable to therapists, but when it is misapplied, it can be damaging. For example, anyone who is chronically subject to political or organizational authority that is arbitrary, chaotic, and abusive will develop paranoid defenses. To assume that a person in such a situation has a paranoid personality based simply on observable behaviors is a serious clinical mistake that pathologizes the individual rather than the context evoking the paranoid reaction. Frequently, psychoanalytic therapists have misunderstood cultural differences as individual pathology. For example, in the United States, South Asian clients used to be often mischaracterized as borderline because culturally their interpersonal boundaries are different from those of Americans of Western European descent. Next, defensive organization. Beginning with Freud's emphasis on repression, displacement, and other unconscious efforts to deal with anxiety and painful affective states, clinicians and psychological researchers have developed a rich literature on different ways we all try to protect ourselves from psychic pain. Some psychopathology is considered to be pathological simply because it reflects the automatic and extensive use of one defense or constellation of defenses. Personality disorders may be viewed in this way. For example, obsessive compulsive personality disorder reflects an over-reliance on the defense of isolation of affect. Schizoid personality disorder reflects an over-reliance on withdrawal into fantasy. Knowing a patient's usual defenses may allow us to comment on them when they appear as patterns in the person's functioning and when they arise in the treatment relationship. Examining these patterns may allow the patient to develop more freedom and flexibility over time. Even in short-term treatments, where such exploration in depth is not possible, knowledge of how a person defends the self allows for more effective therapeutic communication. For example, with the patient with masochistic tendencies who clings to a bad relationship because he or she is more afraid of separation than of physical abuse, the therapist bringing up the possibility of separating from the abusive other will be fruitless and may trigger the defense of avoidance of the treatment because the therapist is implicitly advising the one thing the patient fears above all else, even above physical survival. In cultures in which separation would be devastating for social reasons as well as intrapsychic ones, therapists need to engage with patients in ways that do not set off their legitimate terror of the social consequences of separation and the mechanisms that defend against that terror. Implicit cognitions or core schemas. In addition to the anxiety defense paradigms of early analytic observation, we have come to appreciate how various are the internal cognitive worlds of different individuals. That is, of course, a major contribution of the cognitive psychology movement. Psychoanalysts who have theorized most usefully about this aspect of individual psychology include Harold Sampson, Joseph Weiss, and their students who developed so-called control mastery theory, an empirically derived understanding of the psychotherapy process. They emphasize that each individual develops in childhood certain core beliefs about life, the world, authority, gender, power, and other central issues. If those beliefs are adaptive to the person's situation later in life, they are not a problem. For example, someone whose family was safe enough for the child to conclude that the world is a warm, caring place will probably relate to others warmly and will evoke positive reactions. If the beliefs are maladaptive to the later environment, however, the person will encounter repeated difficulties. If, for example, someone grew up in a family environment that created the belief that love objects will betray one's trust, that person as an adult will treat people with suspicion and hostility and may be referred to psychotherapy for paranoia. Although Aaron Beck and contemporary cognitive therapists have tended to call such maladaptive beliefs irrational, Sampson and Weiss emphasize that children develop a very rational comprehension of their early worlds. What makes an unconscious belief pathogenic is whether it fits with later experience. Control mastery-oriented therapists attend to ways that patients test them to see whether their unconscious expectations are confirmed or disconfirmed in the therapeutic relationship. In psychotherapy, we need to appreciate the patient's core cognitive assumptions. Through the working out of the transference relationship, we hope our patients will relearn and expand on their earliest beliefs, that the paranoid patient will have an internalizable experience of trust, the depressive one an internalizable experience of being good enough, and so forth. With introjectively depressed patients, if we do not challenge their unconscious conviction that their losses and rejections happened because they were bad, no amount of empathic understanding and opportunity to grieve their losses will reduce their depressive tendencies. They may feel better at the end of treatment, but they are likely to attribute the change to the therapist's goodness, keeping the therapist idealized and themselves devalued, rather than emerging with modified cognitions that protect them from future depressive suffering. Affective patterns. Scientists studying emotions have learned that there are a small number of basic affects that characterize human beings across cultures and subcultures, and despite some cultural differences in facial and bodily expressions, these core affects are universally recognizable on the face. Individuals differ in which affects their face expresses and in which order. We each have our own identifiable affective fingerprint or fractal. Therapists tend to pick up those patterns unconsciously. In normal affect, the face changes about every 8 seconds. One indication that a person is suffering with severe psychopathology is that his or her face has become frozen in one affective position. For example, the dead face of the severely depressed person, the frozen face of the terrified individual, or the down and leftward face of a severely depressed person, of a chronically paranoid patient, that angle is a compromise between fear and shame. Rainer Krause's work on therapist-patient dyads has demonstrated that one of the most powerful curative factors in psychotherapy is the therapist's facial affect. He notes that effective therapists show abnormal affect when with patients. In normal affect, in addition to lability every 8 seconds, we match others. We automatically mirror their expression. Their affect sets off the same affect in us. Krause learned by videotaping therapist-patient dyads that in therapies in which the patient and therapist agreed that significant progress had been made, what characterized the video was that the patient showed one facial affect and the therapist responded with another. For example, a man would come to therapy with anger on his face, and the therapist's face would show curiosity about the patient's anger, not responsive anger. Or a woman would come in evincing shame, and the therapist's face might show sadness or anger that someone had shamed her. I think this is what Bion was getting at with the concept of containment. We are trained to tolerate negative affect, to contain it, to metabolize it, and to return it as another attitude, and that fosters growth. I suspect that the power of the analytic couch resides in its forcing analysans to verbalize what they imagine to be on their therapist's face. When a patient is in a state of anxiety that the therapist's affect will match the patient's negative state, an interpretation whose tone suggests a different affective attitude is deeply healing. And when patients scan our faces at the beginning and end of an analytic hour, they may be checking to see whether their affects have been unbearable or whether we can respond to painful states such as hatred with genuine compassion. The 7th area is drive or motivational system. In many Western psychoanalytic communities, it is not fashionable to refer to drive anymore, certainly not inferred drives such as Freud's eros and thanatos. But neuroscientists are giving us a new language for talking about individual differences in motivation, in the valence of human aims. I recommend Mark Solmes's new book, The Hidden Spring. Sorry, I thought I had a slide on that, for a readable summary of much of this work. Such research has related motivation to brain structures and chemicals that differ in degree from person to person. Based on such discoveries, the research anthropologist Helen Fisher has developed a theory of love relationships that divides individuals into explorers, builders, directors, and negotiators, depending on whether they are more strongly influenced by the dopamine system, the serotonin system, the testosterone system, or the estrogen system. This difference is the algorithm behind the personality test on some computer dating sites. The clinical implications of contemporary neuroscientific discoveries about individual differences are significant. Scientists have learned that, not surprisingly, everyone's brain is unique. Part of what therapists need to understand about any patient is a sense of what drives that person, of what we used to call the id or it. It sometimes helps patients to have a neuroscientific language to explain experience that is otherwise incomprehensible. Again, it is important that the clinician not project his or her motivational system. A therapist whose psychology is dominated by what Panksepp calls the seeking system, for example, will have trouble understanding a person who is centrally motivated by the activation of his or her panic system, the separation attachment system that drives relationship. 8, individualistic versus communal orientation. Throughout psychoanalytic history, many theorists have made a critical distinction between individuals who are more oriented towards self-definition and those who are more oriented towards self in relationship. The great research psychologist and psychoanalyst Sidney Black studied this polarity for more than 30 years. Therapists typically try to help patients reach a balance between these orientations. For example, we attempt to help narcissistic individuals who can be quite indifferent to the subjective experiences of others to be more loving, while we try to help overly dependent individuals to have a voice on their own behalf. But the issue is complicated by the fact that different cultures put the proper balance at a different place on the continuum of self-definition and self in relationship. In the United States, we are individualistic to an extreme and arguably unhealthy degree, and we tend to minimize the importance of interdependence. In the more collectivist cultures of the Far East, to behave like an entitled American would earn a person severe social opprobrium. If a therapist is not sensitive to the developmental differences between being socialized toward autonomy versus toward appreciating one's obligations to others, the patient's basic maturation will be misunderstood. If the patient has more of a we self than an I self, in the terms of Alan Rowland, a naive Western therapist may not be able to help him or her. If the therapist is not sensitive to the cultural context in which an individual is trying to work out a balance of self-advocacy and communal belonging, the patient whose cultural environment is different from the therapist's may feel chronically and subtly pathologized. Incidentally, I think that Italian and Mediterranean cultures have a rather nice balance between individualism and connectedness with family, extended family, and community. They are less atomistic and alienating than more individualistic societies and less engulfing than more collectivist societies. Interestingly, and this is not in what I wrote, this is my comment to my translator, Sidney Black's work found that mental health correlates with being strong on both ends of the continuum, that people who measure on several instruments as the most mentally healthy are strong in advocating for themselves when necessary and in surrendering themselves to the larger context when that is called for, sacrificing themselves to the greater good. Ninth, we have internalized object relations, or inner working models, or schema, or many other names this has been called. Much research on personality has emphasized traits, but traits are static and not reflective of the conflicts that most clinicians have understood as organizing personality. We have learned that what defines personality is an internal theme, and that individuals may show traits at both ends of a thematic polarity. For example, while it is true, as the DSM and ICD systems represent, that a paranoid person shows the traits of distrust and suspicion, he or she may also be pathologically over-trusting, as evidenced by the person who believes that a certain political or spiritual hero is flawless. Schizoid people show the trait of withdrawal, and yet internally they long for closeness and may have moments of intense intimacy followed by withdrawal, what Guntrip called the in and out program. Narcissistically driven individuals may appear to have the trait of grandiosity, but internally they are also subject to feeling ugly and shamed. Obsessional people may be fanatically neat, but they usually have an area where everything is a mess. Hysterical individuals may be seductive and simultaneously inhibited about sexuality. What usefully differentiates individuals characterologically is not so much traits as underlying themes, tensions, or conflicts. Here's a whole list of ways of capturing this. Paranoid people are organized around trust versus distrust. Schizoid people are organized around closeness versus distance. Narcissistic people are organized by inflated versus deflated self-esteem. Obsessional people are organized around control versus loss of control. Hysterical people are organized around themes of sexuality, gender, and power, and they can be both highly sexualized and sexually inhibited. Again, I think the PDM is more useful to therapists here than the DSM. The unconscious organizing themes have been referred to in many different psychological languages, summarized in this slide. The clinical implications of understanding the internal conflictual theme of each patient are vast. For example, a girl who behaves exhibitionistically may be expressing the hysterical theme of trying to feel some power in a world dominated by people of the other gender, or she may have a narcissistic psychology in which fear of abusive power by the other is absent, and what is activated is a need to feel important and valued. Many short-term therapies have been constructed around identifying and focusing on this feature of personality, the core conflictual relationship theme. Finally, the severity dimension, the organizing developmental issue. The earliest psychoanalytic effort to account for personality differences was Freud's formulation about whether the individual was fixated at the oral, anal, phallic, or Oedipal level of development. He speculated that depressive psychology reflected oral fixation, obsessive compulsive psychology involved anal fixation, and hysterical psychology expressed Oedipal fixation. Later, Wilhelm Reich suggested that narcissistic personality involved phallic fixation, and other analysts felt that phobic personalities were organized at the phallic phase as well. Although this way of thinking was ultimately not a satisfying or clinically useful way of differentiating type of personality, it became useful in understanding the degree of psychic compromise within any given character type, what Kernberg calls levels of severity. Early speculation that psychosis indicates fixation at the oral stage, where differentiation of internal from external has not yet occurred, eventually matured into a more nuanced version of developmental fixation and its relationship to seriousness or primitivity of psychopathology. Incidentally, considerable empirical support is emerging for the idea of a severity dimension. In fact, level of severity is considerably more related to clinical outcome than type of personality. Post-Freudian developmental models include Klein's elaboration of the early paranoid schizoid position and the subsequent depressive position, later augmented by Ogden's addition of an autistic contiguous position. Mahler's model of an autistic phase, followed by a separation individuation phase, followed by an object constancy phase. Erickson's paradigm of basic trust versus distrust, followed by autonomy versus shame and doubt, followed by initiative versus guilt. Piaget and Sullivan also developed stage theories, emphasizing cognitive and interpersonal development, respectively. Most recently, Peter Fonagy and his colleagues, who based their work on extensive empirical studies, conceptualized development, and here I will just note all these different approaches, and I put them on slides that will be available to you.
Paola, scusami tantissimo, mi dispiace ovviamente fare questa parte, ma bisogna ricordare alla professoressa McWilliams che ha 5 minuti. Mi dispiace tantissimo.
Yes, I know. Thank you. Okay, just begun talking about Peter Fonagy's work explicating the phase of psychic equivalence, followed by the pretend phase, followed by the phase of mentalization. Although these developmental stage models focus on different aspects of psychic maturation, they tend to divide the phases at roughly the same points: the first year and a half, the second year and a half, and the years from about 3 to 6. In terms of the eventual crystallization of a developmental issue into psychic structure, we have become clinically accustomed to thinking about whether a person operates at a symbiotic psychotic level, in which self and other are not well differentiated, or a borderline level, in which self and other are cast continually into all or nothing categories, bad versus good roles, and interpersonal opposition, or a neurotic level, in which the patient can reflect on internal conflict and understand the mental separateness of the therapist. These inferences have critical implications for how we make a therapeutic relationship and approach our clinical work. Here are some authors that talked dimensionally about different types of personality. Understanding the developmental preoccupation characteristic of each of our patients is critical to therapy and healing. Kohut's critique of the ego psychology tradition, for example, might be viewed as his challenging his colleagues to think about processes that are earlier and more fundamental than the Oedipal drive satisfaction issues that many psychoanalysts were assuming motivate any analyzable person. Recent writing from the perspective of trauma and dissociation concludes that extreme experience can catapult any of us back to the preoccupations of earliest development, that is, safety and survival. Traditionally, analysts spoke of supportive therapy for those in the psychotic symbiotic range and exploratory therapy for those who are organized at the neurotic level. For those in the borderline and dissociative areas, there have emerged from clinical experience and scientific investigation a range of psychoanalytic treatments, including the contributions of Kernberg and his colleagues, Masterson and Rinsley, Bateman and Fonagy, Russell Mears, Gregory and Remen, Clara Mucci, and others. The work of Marcia Linehan and Jeffrey Young in the cognitive behavioral tradition has considerable overlap with such analytic models. Despite differences in specific focus, all these approaches, and I'm moving to borderline now, emphasize agreeing on firm boundary conditions, expecting powerful either-or experiences, bearing intense transference enactments, and integrating starkly dissociated elements of personality. Psychotherapies with such patients are inevitably intense and difficult and require the clinician to have a supportive group of colleagues who understand the stresses involved. In conclusion, in my own experience as a therapist, I find it valuable to shift perspectives frequently and fluidly as I think about how any particular patient may be best seen and engaged in each context, in each moment. Every one of these lenses through which human individuality and mental suffering have been viewed adds a clinically valuable way of understanding each person's unique psychic life. Thank you for your attention and interest.